Hello, everyone. My name is Dr. Hafsa, and I hope everyone has logged in by now. And so
Hi,
today,
Dr. Hafsa. Just interrupting you in the middle. Just wait a little bit. We will start just in 5 minutes. Okay.
okay,
And just have a look on your messenger. I just send you a message so that we can just during the class we can also just interconnect with each other.
sure, doctor.
Thank you. All right. Good evening, everyone. Welcome to First Aid PESCI introductory class today. And also with me, Dr. Hafsa is here, who is going to be one of your mentor. Now, as all of you, I think, know about us, and that's why you are here today to know about the PESCI course. And I'm sure that you also know that this is our first session that we are going to do with PESCI for you. And throughout the, I think last 5 years, I always got a huge amount of messages from many of you to start this PESCI course. And I never actually got the time to start it, but now it seems like I have got some help with Dr. Hafsa and some other good doctors who also can be a part of these classes. And then together we can obviously make a very good course, just like how we are doing in AMC. Now, today is a free class for everyone. That means that our course hasn't started yet. And if you are part of the First Aid PESCI course, then you must have known that what's the course is going to be and what we are going to offer you. And then also today we are going to just have an introductory session just to know about PESCI a little bit. And also you can ask questions about whatever you feel that you need to know about it. So we will be happy to help. Now, many of you might think that, well, like do we have experience in GP sector? So that we can help you or not? Yes. So to answer that questions, I have worked in GP for 3 years. So I have a very good experience in GP. So if there is any specific part of GP questions that you need to ask, I know each and everything about it. So in that way, there will be no issues. And most of our mentor is also going to start as a GP in just few weeks to months. So I hope that you guys will get immense amount of preparation with us. And also the main thing is to understand about PESCI. It's just an interview, and it's not like a conventional interview that we do that just go in and ask some questions. It's not just like that. It's a specific interview that you guys need to do to start working as a GP in Australia. Now, in terms of hospital and GP pathway, the best idea to be a GP is that there is a very good work and family balance in here. You get all the public holidays, you get all the holidays, which you can't get in hospital. And this is actually really good. If you work in hospital, you will actually feel it, that how good the GP can be as part of your having a life. It's not all about earning money. Having a good balance in the life actually matters a lot. If you can't be with your kids in a public holiday or even in Saturday, Sunday, that life, a lot of people will not love that life. So I guess that you guys actually want to be a GP because you feel that work and life balance is very important for you. And I really appreciate that, because that's actually a very good idea. And I'm sure that you will love it. There is no GP who ever said that they don't love their job. Okay, so I'm sure that you will also love it. Now, about the course, I'm just going to discuss a little bit, and then I will hand over to Dr. Hafsa so that she can start the session. And we will give you some time at the end also to ask some questions. I will be here today listening to all of you, and we will also like for you to come and do some role play with us so that we can see where you are at the moment. So Dr. Hafsa, just excuse me for a moment. I'm just going to share my screen so that I can share the notes, share about the course a little bit, and then we can start.
Sure, doctor.
So I'm sure that all of you is a part of our first aid PESCI group. This is like just a very preliminary group we just created not even a month ago. And many of you are from our AMC, MCQ and clinical course. So you already know about us, and you're here because you obviously you were satisfied with the course that we have provided you. And I'm sure that you will also love it. Now, PESCI course that we are going to offer is a little bit different from the AMC clinical and MCQ that we offer. Unlike clinical PESCI course, we don't actually offer for a longer time. Like if I ask you to come for a 5 months course for PESCI, in 5 months time, you might start working as a GP in Australia. So that doesn't work for you. So we have made it in a way so that it works for you. Now, there are lots of courses who just gives a 1 week course. And I'm not sure how actually any of you can get benefit from such a preparation, because 1 week cannot be enough for a PESCI preparation. It is something that will allow you to work as a doctor in Australia. And it's not something that very easily passed. Same like clinical, PESCI has its own passing rate. Passing rate is not like MCQ that you go and just pass the PESCI. It's never like that. So you'll need to be very much confident. You will need to actually show that, yes, you are the right candidate to work as a GP in Australia. So your interview should be like that. And we are going to help you with that preparation. With a lot of discussions, I came to the final duration of the course as 6 weeks. It seems like the best time to prepare. And if you can finish everything that we ask in 6 weeks' time, then I'm sure that you'll be a well-prepared candidate to appear for that interview. So the course is going to start on 29th of May, but the class might start from 1st of June. So we will just see that if like when will be the best time to start. So 29th of May to 10th of July. So today is the trial session. Now, this first course is mainly focused on IME. not any others. But saying so, we will try to give you a basic idea that can cover RSCGP or ACRAM as well. Our idea is to provide IME course in 6 weeks, and the following 6 weeks we will do RSCGP, and then again IME, then again RSCGP. In that way, it will rotate every month. We will try to cover at least the last 3 to 6 months cases so that you have a good idea. And we'll try to do at least 150 role play with you in the 6-week sessions. So 6 weeks, you get 4 classes every day, like 4 classes in a week. That gives you about 24 to 26 class in your 6-week session. And we will start the class from 7 and we'll finish at 9 or 9:30 p.m. Okay? So basically it's like clinical exam, but it's a different way of preparation. But I say that if you have a fair knowledge on clinical cases, your preparation is already 50% done. The other 50% is just to get an idea that how this exam is gonna be and what they actually look for you and what you need to work on. If you have already done our clinical course, your preparation 50% is done. There are a lot of candidates who pass even from clinical course. So I would suggest you that these 6 weeks will be a interactive sessions with us, which means it's not just about like coming to the class and just listening to our classes and not doing anything. It should be an interactive session. And obviously you will get a lot of chance to do role play. Okay? And we'll try to do each case role play so that you get a good feedback from us. Now, the best thing about this course is that there is no course you might be able to find so far that who offer the course notes or video recordings of the class. So we are going to offer the course notes just like we have done in our AMCs. You will get course materials, you will get video recordings, you will get everything that you need to prepare for this exam. Okay, so let's start the session. If you have any more questions, feel free to ask me or Dr. Hafsa. And now I'm going to hand over it to Dr. Hafsa and she's going to go through everything with you. All right, thank you guys. Dr. Hafsa, you can start.
Thank you so much, Dr. Arshan, for such a nice introduction. Now let me just share my screen and then I will be done. Okay. Hi, everyone. My name is Dr. Hafsa, as I already told you. I recently cleared PESCI through IME, and today I will be taking your PESCI introductory class. So I know that most of you already know so much about PESCI, but some of you might not be aware much about PESCI. So let me tell you. So PESCI is a clinical interview. It's not an exam. So in AMC clinical, you are familiar with the pattern that you are there to perform in an exam and no one interrupts you usually, or usually the examiner does not interrupt you. It's an interview, and in interview, the interviewers, they interrupt you, they ask you questions, they may interrupt you, okay, do not tell us about history, tell us about management first. What are you going to do? Then in PESCI, 4 cases are given, and you have to pass all these 4 cases in order to clear your PESCI interview. Usually, there are 2 case discussions and 2 role plays given. Role play is just like AMC clinical, like whatever you do in AMC clinical, it's just like that. There's a simulated patient in front of you. In case discussion, they give you a case and you have to talk about what are you going to manage and how are you going to approach that case, or there will be tasks according to that case. And in case discussion, you just have to talk and what are you going to do? All right. Then, but it's not like a hard and fast rule that it will always be 2 case discussion and 2 role plays. Some students have told us that there were 3 role plays and 1 case discussion, and so it can alternate. Sometimes there were even some students who said all the cases given to them were as role plays. So there are usually 15 minutes for each case, but there is no clock There is nobody even tells you that there are going to be 15 minutes. And during these 15 minutes, you have to perform and also let the panel ask you some questions. So whenever you practice, make sure you complete your all tasks at least 10 to 12 minutes, and give the panel at least 3 to 5 minutes so that they can ask you some questions. Okay? All right. So for PESCI, it's clinic specific. For every clinic, you just you have to give one PESCI. If you want to switch clinic, or for example, sometimes the clinic back out and they say that we cannot supervise you, supervisor is not available at the moment, then you have to find another clinic and you have to give PESCI again for that clinic. So it's clinic specific. All right. So whenever you apply to clinic for a job, you need 3 things from them: a job offer letter, a training plan, supervised practice plan, and a position description. So then there are 3 regulatory bodies through which you can give PESCI. The most commonly and most old, what I would say, is RACGP, very slow, and they take a lot of time to even book your PESCI. So other than that, there is ACRRM and Institute of Medical Education. So they are a bit fast and they can give you dates quickly, especially IME. Their booking process is really smooth. So I gave PESCI through IME and I really liked them. So yes, Institute of Medical Education, IME, they have been recently authorized to take PESCI. Before that, it was only ACRRM and RACGP. So RACGP is usually slow, but there are usually PET 62 cases. But still, I've heard that passing rate of RACGP is very low, as panels, it depends on the panel that is taking your interview. Sometimes there are very strict doctors in the panel who don't let you pass. All right. So mostly PESCI is given as a level 1, level 1 supervision. If you want to have, the clinic gives you level 2, it's very hard to pass. As an IMG, they usually ask level 1. Okay. So when you are preparing for PESCI, you can take a snapshot of this slide as well. These are health pathways. So whenever you have any a question or any, if you feel like how to manage croup, or for example, how to manage bronchitis, just use this health pathway, write bronchitis in the search bar, and everything according to related to bronchitis will appear, that what's the management plan and everything that you need to know. Even the GPs who are working in the system, they use these pathways. All right. So it's for every state, there is different password and username. So you can use that. And you can use that for, if you are in NSW or Victoria, you can use that for giving PESCI, okay? All right.
Yes, sorry, Dr. Hafsa, I will just interrupt you a few times. So that's actually right, guys. So what happens if you don't, if Dr. Hafsa, if you go back to this one, this is actually a very good thing, because even I used to use all of those, especially when I worked in Queensland. This was like one of the best thing, especially when you will be starting as a GP. I'm sure that in your computer tab, this one will open all the time, because it gives you all the ideas, all the guidelines, and the pathway of referrals, which as a GP you are supposed to know. That means that when you are a GP, you actually need to know your position, that you are a junior doctor there. As Dr. Hafsa said, that you are just a level 1 doctor who needs to discuss every case with their supervisor, so that you can do some management on that patient. You are not supposed to manage a patient without discussing that case with the supervisor. So even before you discuss this with your supervisor, you need to have some idea about that. So what you could do is that you can at least go through the guideline, and any of these, especially wherever you will be working, if you open up, you will get the current guideline. You will know that what are the emergency criteria that you need to send this patient to the hospital. You also would know that which criteria fulfills that you can just send the patient to the hospital as a referral. So 2 things actually as a GP we do. One thing is that if a patient needs urgent management, we straight send them to the hospital. But as part of PESCI, you will first discuss the case with the supervisor. If supervisor feels that that is the right way to do, then you are going to send the patient to the hospital. Sometimes as a courtesy, we even just give a call to the emergency department SMO or the register on call so that they know about this patient, especially if it is a very serious patient. The other part is that this guideline will also show you that, well, which patients actually can go to the hospital as an outpatient doctor. That means OPD department. So all hospital has a OPD department of every categories like respiratory, cardiologist. So some of these patients will go to the OPD department, and those are actually non-acute or non-emergency cases. And when you send a referral, we use the smart referrals. So these things actually, like as a PESCI candidate, you are supposed to know it. Although you did not work in Australia, still they would ask you, especially the RSCGP interviewers, they think you already started working in here, but that's not the case. But still they ask a lot of questions that you might not able to know if you don't work. So smart referrals we always use as part of the referral to hospital. So if we want to send a patient as a non-emergency, we write the full referral in the smart referral. It's kind of a website. And in that, you will submit the referral. After submission, the hospital will come back to you that what category is this patient. So they divide the patient into category 1, category 2, and category 3. Category 1 is basically should be seen within 30 days, category 2 within 90 days, and category 3, 365 days. So based on that category, the patient will go to the hospital. And ideally, the hospital will also send an appointment letter to the patient's post that this is the time you are supposed to go to the hospital, this department, and we are going to do this. So that's how the referral system works. I just wanted to let you know that sometimes they just ask you like how you're going to make the referral. So you know that smart referrals is the way to make referral in the hospital system. If you need, like, let's say a patient has private health cover. They don't need to go to the public system. They can see a private doctor, any private specialist. In that case, we don't use smart referrals. We use medical objects. So that's a different kind of way of sending referral. Okay? All right, Dr. Hafsa, I will just interrupt you time to time, just in case if I remember something, so that this can be helpful for others. Okay, you can continue.
Thank you so much, Dr. Arshan. So talking about referrals, so because Dr. Arshan just pointed towards it, whenever the panel asks, always say, I will use ISBAR protocol to refer my patient. That is, I will introduce myself and the patient, situation that the patient came in, the background assessment that I have done, and then I will refer the patient. So just follow the ISBAR protocol, all right? Then Asma wrote something that PESCI has no expiry. No, it's not correct. PESCI has expiry date of 1 year. It's only valid up till 1 year. And then someone said that if you can change clinic in the same MMA area, then PESCI may be valid. So what happens is if like these things are, if you have any questions, you can write at the end at the chat in the chat box. I will be happy to answer. But let me answer this one that because if you gave PESCI, you already applied for registration, and then the clinic refused that they cannot supervise you. Then what you need to do is find another clinic if it's in the same demographics. And if you don't want to give PESCI, what you can do is you can prepare PESCI comparability report and then send it to AHPRA, and then it's up to the AHPRA panel if they approve it or not. If they say you have to give PESCI again for the other clinic, then you have to give it. So usually sometimes they accept, sometimes they do not. It depends on AHPRA panel and the clinic, the next clinic you choose, if it has same demographic, same distance from hospital or anything. Usually AHPRA is very strict in accepting PESCI for two same different clinics. All right. Okay, let's move. Sorry, we altered a little bit. Okay. So yes, let me discuss case 1. So whenever you will start your PESCI interview, first of all, the clinic will ask you to introduce and identify yourself using your passport or your ID card. Then the second thing they would ask you is what level of supervision are you giving PESCI for? Usually it's level 1. Then they will ask you, what do you mean by level 1? Then you have to say that level 1 means I am not allowed to see any patient independently. I will only see patients in the presence of my supervisor whenever the supervisor is present at my clinic. And every my history, my physical examination management would be supervised by my supervisor. Even I'm not allowed to take any phone call in the absence of my supervisor. Then they will say, okay, this is your first case. Tell us, what are you going to do? They do not give you reading. There is no reading time in IME. They just say, and then they want you to just go in a blink of moment. Okay, so take your time, take a deep breath, just relax, and then scan the situation, the case, and then proceed. So the first case, for example, is given to you is a Matilda, 30-year-old woman, coming today with a skin lesion, which she's suffering from for more than 6 months. All right, she's a smoker, social alcohol drinker. She has no family history. She's allergic to penicillin, and her vaccination is up to date. So usually the tasks are written in front of you in RACGP and ACRRM. For IME, when I gave it, there used to be no tasks in front of you given. It's just like they give you verbal case, and then they ask you to proceed. Sometimes they can show picture even on the video camera, and then you have to proceed. Okay, so but right now I've heard that some IME panels are using slides as well. Okay, so usually the first question they ask you is, here is a picture of the lesions. How are describe the lesion? How are you going to describe it? So first of all, always start with, thank you panel for giving me this case. So it makes them feel that you are a calm, composed doctor. Then the next is that you want to say that there is a picture of my patient's legs. For example, first of all, you are going to say, I can see the rash, and I'm going to describe the A, B, C, D, E of rash. So first of all, I will describe A, which is area of the rash. I can see that the rash is present at the posterior aspect of the legs. And B is for border of the rash. I can see that the borders are irregular, well defined. C is for color. I can see that the color is pinkish to red. D is for diameter or size of the rash, which I would like to measure with the help of a ruler or an inchy tape. Then E is for extent of the rash, and D is also for description. I can see silvery whitish scales on the lesions, no bleeding, no oozing, some mild ulcerations. Then I would like to palpate the rash to notice its firmness, elevation, tenderness, warmth, and any discharge, so I can comment on it. Then then I'm going to ask history in detail about the rash. So first of all, I'm going to talk to you this as a case discussion, because you haven't done case discussion. And the other case, I will do a role play with you guys. Okay. So then they ask you, how are you going to approach this case? So first of all, make one liner for every case. So panel, what I would do is I will go to the waiting area, invite my patient to the consultation room. While doing that, I will notice general appearance of the patient. Once in the consultation room, I will try to build up a good rapport with her, make her feel comfortable. And I will be very empathetic and be an active listener and explore my patient's ideas, concerns, and expectations. I will ask some detailed questions about her chief complaint. So then where exactly is the rash? Is it first time it's happening? Did it happen suddenly, gradually? Is it constant, on and off? So does it appear at any specific time or any specific season? Then first of all, is it distributing towards any other part of the body? Any growth, progression? And how fast is it going towards other areas, any specific pattern? All right. So then you can talk about characteristics of the rash, if there is any pain, any itchiness, any scaling, swelling, any bleeding or discharge. Then if there is discharge, you have to talk about color, consistency, volume, and odor, CCVO. All right. So then you have to talk about its severity, if it's affecting her life, and how she's coping up with it, any aggravating relieving factors, like any exposure to hot, cold, any sun exposure making it better or worse, any ointment or moisturizer. Then if she has used any medication or gone to any doctor for this so far, and did it help her or not? All right. Then you can ask about associated symptoms. If she had any fever, chills, any malaise or fatigue, if she had any skin changes in other parts of the body, any joint pain, any swelling along with it. Why are you asking it? Because if it's psoriasis, you have to know about psoriatic arthritis. All right. She has a rash. It could be infective, so you have to ask about all fever, chills, and makes the panel know that you are a safe doctor and you know these things. Okay. So any scaling of head or skin, any nail changes, for example, gutted psoriasis, any oral ulcer or lesion. Why are you asking about oral ulcer or lesion? Because you have to make sure that the patient doesn't have any inflammatory bowel disease along with it. All right. Any eye problem, discharge, any GI symptom, nausea, vomiting, abdominal pain, any urinary symptoms. Then any change in her appetite, any unwanted change, any lumps and bumps in her body. Okay. You are asking about this to know about the immunocompromised status of the patient. Okay. Then you can ask about if anyone in the family having similar kind of rash, if she has used anything new, any medication that brought on this rash, any recent immunization, and anyone in the family or any contact with someone with any similar kind of symptoms. Then any excessive sun exposure, sunburn or tanning, any recent travel trauma, any recent stressful situation. So you have to know about all that. Okay. Then, talk about past medical history, family history. So psoriasis can run in family as well. Okay. So you have to ask about any skin cancer in the family as well, any history of atopic or rheumatological diseases in the family. Then talk about what medication she has been taking, lithium, antimalarial NSAIDs, or steroids. If she has been taking that can worsen psoriasis. Okay. So besides penicillin, because it was written in the case, has she got any allergy to anything else, any medication, or any hospitalization, any history about that or not? Then psychosocial history, smoking, alcohol, sadma questions basically. So you have to ask about those as well. Then home job situation. If you feel like the patient appears to be depressed, it's a role play, and you feel like patient is depressed, then you talk about mood, anhedonia, trouble sleeping, and her job as well, and if, to rule out any contact with any chemical material. Okay. So then if it's a case discussion, say that it makes a good impression at the panel. Say that I'm going to ask her about if she's getting depressed, and I'm going to screen her for depression as well, because psoriasis is a condition that can cause depression in some patients, especially females. Then then the next task can be demonstrate how are you going to examine Matilda. So again, make a one-liner for every examination case. So thank you, panel. What I would do is I would follow the standard protocol. I'm going to wash my hands. I'm going to then take permission from the patient by telling her what I'm going to do and how I'm going to do it. And also I'm going to offer a chaperone to respect her privacy and dignity. I will ask her to sit in the middle of the bed under good light. Then then tell that panel that I'm going to check my patient's general appearance to see if there is any pallor, icterus, any edema, lymphadenopathy, any signs of dehydration. I will make sure my patient is vitally stable by checking her pulse, respiratory rate, blood pressure, and also her temperature and BMI. And then I'm going to make a focused examination on her skin. So can anyone see clearly? I'm sorry. Okay. So then what else you are going to do is you say that I'm going to do a focused examination on her skin. I will follow a systematic approach to cover all the parts of her body. All right. Especially those areas that the patient might miss, for example, the back of the patient and also the nails. While she is sitting, so always go from head to toe. that would be my approach in doing every examination so I do not miss anything. So I will check the scalp, eyes, ear, behind the ear, face, mouth, mucosal areas, neck, shoulder, elbow, flexor and extensor areas, hand, palm, and fingers, check between fingers and nails. All right. So I will look for changes of psoriasis, for example, pitting nails. I will look for onycholysis, separation of the nail from the nail bed. I will look for any fungal infection in the nails to rule out my differentials as well, and also notice any yellowing and ridging. Then I will ask my patient to lie down in supine position. I will check her chest, her tummy, abdomen, legs, ankle, foot, soles, toes, and between toes and nails. Then I'm going to ask my patient to roll over, check back of legs. So if you go from head to toe, you are not going to miss anything. All right. So after explanation and taking her consent or permission, I will check butt, and in the presence of a chaperone, I will check buttocks and the genital area. All right. Okay. Then during the second examination, I'm again going to look, feel, also use a magnifier to have a look at the rash. I'm again going to talk about A, B, C, D, E of the rash, exact area or site of the rash, its border, color, distribution, and characteristics of the rash, and extent of the rash. Then I'm going to do the over the feel part. I'm going to see if it is elevated, firm, tender, warm, blanchable or not, or if there is any discharge or bleeding. Then I'm going to present my history and examination to my supervisor and do a dermoscopy. And if my supervisor wants me, I will do the Auspitz test. The Auspitz test is a test for psoriasis in which there is any removal of thick scale that can cause pinpoint bleeding. Okay, so yes. Then with my patient's permission, I will take a photo with the help of my mobile to keep it as a baseline before any treatment. Then if she's having any joint symptoms, I will also examine her joints. I will examine cardiovascular system and abdomen, looking for any abnormalities, and office test, blood sugar levels, and ECG after consultation with my supervisor if my supervisor wants me to do them. Okay. All right. Then they say, okay, what is going to be your differential diagnosis for Matilda? So before proceeding towards any case, at least make sure you have 4 to 5 differentials in your mind whenever the case is given to you. So usually whenever a rash is given to you, this rash, because it is psoriasis, so first diagnosis that you should say is psoriasis. Then the most common diagnosis that should be the next. All right. So usually the commonest is atopic or allergic atopic dermatitis. Then you can talk about seborrheic allergic contact dermatitis. So these are 3 types of dermatitis can be your differentials. Okay. Then allergic dermatitis is another. Fungal infections are common as well. Okay. Any drug eruption, that can be your diagnosis as well. Lichen planus cutaneous T-cell lymphoma. If you skip it, you don't say it, I don't mind, and panel would not mind as well. Okay, until it is a case of lichen planus and you miss it. All right. So make sure you say at least 4 to 5 diagnoses. Usually panel is happy with it. Okay. All right. Then usually the panel asks is, okay, what are your investigations for this patient? What are you going to do? What blood test you would do? So because then you would say, okay, because psoriasis is a clinical diagnosis, but to be a safe doctor, I'm going to rule out some possible associated diseases, for example, hypertension, diabetes, cardiovascular diseases, inflammatory bowel diseases, obesity, depression. So in office test, I can order blood sugar level and ECG after consultation with my supervisor. If the patient appears depressed, I would offer her K10 questionnaire to screen depression. For investigation, I will do baseline investigation. For example, blood sugar, full blood examination, liver function test, lipid profile, ESR, that is an inflammatory marker, CRP as well, or a urine mid culture and sensitivity. Then lipid profile is important to calculate cardiovascular risk assessment. If the patient has also complaints of joint involvement, Then you will order rheumatoid factor anti-CCP and X-ray to rule out rheumatoid arthritis. Okay. Then the next question they will ask is, okay, what is your management plan and when would you like to see her again? So when they say management, it means everything. First of all, like your first line would be, first of all, I would like to educate my patient. I would tell her what psoriasis is. So I will tell her it is an inflammatory condition of skin, which is it is in which sometimes our defense system starts attacking the skin, and our skin starts producing so many cells that it becomes thick, and the dead cells doesn't shed off as rapidly as the new skin cells are producing. That's why her skin is so thick. So in layman terms, so my patient can understand what psoriasis is. I will tell her about the cause, commonality, and prognosis of this disease. I will reassure her that it's not contagious, it's treatable, but it has a relapsing and remitting course. That is, it comes and goes. Then I will explain that there are some triggers, for example, stress and some medications that can exacerbate or trigger psoriasis. So it's better to avoid them. So even if you say at least one or two drugs, for example, it's a female patient, make sure you say OCP, NSAIDs, because these are very commonly taken by every patient. So I will educate my patient to avoid them. All right. And I'm also going to give her some reading materials so that she knows about psoriasis. Then first of all, I will advise her on lifestyle modification. So I will tell her about some important comorbidities like metabolic syndromes, hypertension, obesity. I will advise her if she's smoking, alcohol reduction, have a healthy balanced diet, and keeping healthy weight and doing regular exercise. I will give her general advice to avoid triggers. For example, stress, sunburn, hot water. There are some triggers which you can read that can reduce the remittance of psoriasis. I will advise her about some relaxation techniques and having moderate amount of exposure and also taking some short shower. All right. So these are the things that you can tell your patient. Then I will consider activating GP management plan and a reminder system for my patient. And I will arrange a follow-up visit to check her condition. So for every disease, there is a GP management plan. For every chronic disease, for example, diabetes. So there is a GP management plan in which a patient can have 5 to 10 free visits with their GP. And there is a reminder system for every, like they get a call from the clinic that your appointment is coming up. Are you taking your medications? And then they do come in so that the patient has an idea the clinic cares about them. So it's called GP management plan. So first of all, I will offer her pharmacological management as well. I will start with corticosteroids. The first line management is usually corticosteroid like TAR or calcipotriol. If it didn't work, then in follow-up visit, I will check her condition and response to the treatment. Then I will, if like still after 3 months, I'm going to review her. Usually with psoriasis, you review after 3 to 6 months, depending on patient's condition, if it's mild, moderate, or severe. So if it didn't work, I will continue with topical therapy like steroids plus TAR or calcipotriol. Then also you have to give patients some reading material and some support groups. You can offer Psoriasis Australia, or there are some support groups on Facebook as well regarding psoriasis, in which there are patients who are suffering from psoriasis and they share their stories so that the patient knows they are not alone. Then I'm going to review her after. So the first time if the patient comes and she has never been diagnosed with psoriasis, so say that I'm going to review her in 3 weeks, then on regular basis to check her condition. Then when are you going to refer the patient to specialist or dermatologist? So if the first of all, usually in the commonest cause is in the PESCI cases in IME, the patient is very depressed, you have to refer. So if it's causing enough discomfort, the patient's lifestyle is getting effective, you have to refer. Psoriasis is very extensive, inflamed, unstable. There is pustular psoriasis, and the nails are getting affected, which there is pitting nails, there is no response to local treatment. So at least 4 to 5 criteria you should know that when are you going to refer. Usually it's a very common questions asked by the panel. Tell us a few indications in which you would refer your patient to dermatologist or specialist. Okay, so management plan always talk about cost, commonality, condition, and prognosis. Okay, so then you have to talk about first line treatment. It's always steroid. Okay, then other than that, what can you do is add calcipotriol or tar. Then there are the other only GPs can do only these drugs usually. The rest of the treatments are usually given by specialists. Okay. So any questions so far?
All right. Thank you, Dr. Hafsa, so much for it. I really loved it. So just to add with this management, normally what we do in GP setting for a psoriasis management, all of the things that we have discussed, it's really important. But in terms of management, the important part that yes, for most of the body part, we will start with the steroid. And they sometimes can ask you that what kind of steroid that you want to use in this patient. So it's not a bad idea to know about the potency of a steroid, like which steroid is low potency, which is moderate, and which is high potency. Like for any form of psoriasis, if it is not on the face or not in the genitalia or any mucosal membrane, we will always use a high potent steroid, which most of the time is betamethasone dipropionate. So that will be our first choice. They can ask you that, so what will you want to use it on the face? Face, we never use betamethasone because it's a very strong steroid. So we will use a low potency one, which is 1% hydrocortisone. You can see it on the just on the lower part of this slide. So face or flexural surface, like any of the flexor could be your between the knees, between the elbows, those flexurals, we use just a low potency one, like 1% hydrocortisone. And tar is not our first line management. Usually never we give tar. Most of the time, first we would start with betamethasone. For 4 to 8 weeks, we will try it. If that doesn't help, then we add calcipotriol with it. And there is a very common name for it, which is also written, divovet. That's usually the one that we try. And then even after that, if patient gets like, patient can't take betamethasone, patient can't take calcipotriol, they're getting some effect from it, then sometimes we can choose tar. So don't say tar before calcipotriol. Calcipotriol will be your second thing. Okay. All right, Dr. Hafsa, thank you.
Thank you so much, Dr. Arshan, for adding this. One more thing that I would like to tell you, and it's a really common trick used by people to clear PESCI, and that I used as well. For example, they are asking you what is the first line treatment for this disease, and you don't know what is the first line treatment or the second line treatment. What you can say is, I'm going to check into the health pathway, see what's the best first line treatment for my patient. And even if they ask you, okay, when are you going to ask your patient to come back to see you? I'm going to check into the health pathway and see what's the best time interval for my patient to come and visit me again. And I'm also going to discuss with my supervisor that what would be the best time interval to review my patient again. So that you are at level 1, the panel accepts it, and usually they appreciate it that you are being safe and you're consulting your supervisor as well. So make sure you always use this trick. Even if you are sure about your management plan, always ask that. I'm going to also make sure, look into the health pathway, make sure I'm not missing anything, and make sure I'm also involving my supervisor, and my supervisor is happy with the management plan I'm making for my patient. That's it. Just one line. So that would make the panel happy. All right. So everyone with me so far? Okay. So it depends on you. whatever you want to mention, lifestyle management first or pharmacological management first. So usually psoriasis is a clinical diagnosis, and lifestyle management has a major effect on psoriasis. So always talk about that as well. Then you can talk about the non-pharmacological management as well. Then you can say focused examination, always need to say general examination as well. So it depends upon what your task is. If they ask you to say, okay, just describe the rash, okay, then you just need to talk about the rash and focused examination of the rash. But they say, okay, how would you examine the patient? Then you have to talk about all about not only focused, but a general examination as well. Okay, hope that answers your question, Samreen and Javed. All right. Okay, so let's move to the next case. Everyone happy if I move to the next case? Hope so. Okay. All right. So this is a case of headache, and it's very common complaint with GPs. So usually headache can come with any, the scenario can be changed. Okay, so in this regard, it's written that Jamie, 42-year-old male, came to you because he's having a recurrent headache, and he has been irritating him for the last couple of weeks. He's a school manager. He takes paracetamol, Panadine Forte with little improvement. So there can be, how are you going to approach it? They can give you a examination card. What's your differential diagnosis? What are the investigations? What is your management plan? So these can be tasks written in front of you, or they can just say verbally the first task, and then they can ask the next of the tasks meanwhile you are performing. So anyone is willing to do role play, interested to do role play? Who is the brave one? Okay. All right. So Ulgan and Russ. Ulgan, okay. If Ulgan can unmute yourself, you can I'm not sure if I'm pronouncing your name right.
Yeah, I did.
Okay. Hi. So you happy to do role play on this?
Yes.
That's great. Okay. So let's suppose I'm going to give you just 12 minutes. Okay. I'm going to start my time. In the real exam, you would not be told about time or anything. It's just that I want to see how much time you are taking. Okay.
Okay.
All right.
I'll
Okay.
start with the role play, or do you want me to mention about how I should approach to this case first?
Okay, because we did a case discussion first, I feel like it's let's do a role play, because then it would not be it wouldn't seem appropriate if we do two case discussions.
Okay.
Okay.
Hello.
Okay, I'm your panel, and I'm going to give you this case, and your time for this starts now. Start.
Okay. Hello, I'm Dr. Ilgan, one of the doctors here in GP practice. How may I address you? Can I address you, Jamie?
Yes, doctor. My name is Jamie, and oh my God, doctor, please help me. I'm having this, oh my God, this stupid headache.
I'm sorry to hear that you have such headache. Let me first check your hemodynamic stability. Is everything all right or not? Is my patient hemodynamically stable, panel?
Oh, doctor, nurse checked me. I'm fine. Plus, headache, I can't bear it. I don't know what's going on.
Can I offer you painkiller, Jamie?
Yeah, sure.
Do you have an allergy?
No.
Well, okay, now I'll arrange it for you. Jamie, can you tell me more about these headaches?
Doctor, it's always there. And, you know, I work as a school manager and expecting my job now. I can't work with this stupid headache. And, oh my God, it's bothering me a lot.
Oh,
Please,
it must be, yeah, I'll try my best. It must be difficult for you. I can understand you. Well, I need to ask you questions so that we can find out the problem and do a management plan for you. Is that all right with you?
Sure.
Everything we discuss here will be kept confidential, Jamie. So you can tell whatever you have. Well, first, let me ask, how long have you that this pain?
It's been going on for, last maybe 1 to 2 months, right now, and I have been taking paracetamol, but it just helps a little bit, but not much. It's
And
just there.
well, where is the pain?
Oh, it's like at the back of my head and neck. Yeah, it's always there.
And the intensity, on 1 to 10 scale, how severe is it?
Yes, doctor. Intensity, you can ask when you are, giving painkiller. So
Yeah.
yes, doctor, it's like maybe 6 to 7.
6 to 7. Well, can you tell me the quality of the pain? Well, it is like bent, like constricting, sharp, or how can you describe the pain?
So doctor, it's like always there and sharp.
Sharp. And how long does it last?
So it comes and goes, and it's like almost like it's always there, doctor. I feel like it doesn't go away much.
And how often do you have this pain in a week, maybe, when it comes?
Almost every day, doc.
Every day. Okay. And did you notice anything that makes it worse or better?
So whenever I'm working, I'm like, I work on computer a lot. That makes it worse. I'm a school manager, so yeah, that makes it worse. So whenever I'm angry, that makes it worse.
Stress,
Oh my
the
God.
human.
Yeah,
Weekdays, weekends, does it make a difference?
not much.
Well, can you?
Due to this anger, I'm always due to this headache, I'm always angry, and I'm having trouble with my family as well. I'm getting like acting out on them.
Okay. Well, do you have any fever, any rash,
No,
any recent upper viral infections like runny nose,
no,
discharge? Well, do you have pain when you lean forward?
no,
Early morning headaches, nausea, vomiting?
no,
Well, do you have any past medical illness in the past, that like hypertension, diabetes?
no,
Well, and can you tell me, other than paracetamol and Panadol, did you try anything?
no.
Did you
I
go
don't-
to?
I can't get any medication instead of paracetamol or Panadol from pharmacy. So that's the only thing I could get for my pain. Yeah.
Did you ever visit any doctor and any investigation done before?
No investigation. Then I went to some doc, but he just gave me paracetamol, Panadol. That's it.
Well, this pain that I mean started all of a sudden and increased in a very short time. And is it with any nausea, vomiting, any visual impairments, that visual?
No, nothing like that.
Ever had any fits, like
No,
funny turns?
no,
And did you notice any pins and needles, any weakness at your arms, legs,
no,
any balance problem when you are walking or when you try to stand up?
no,
And this pain that you said just at your back of your head, do you have any pain at one side of your head, at your temples? Did you notice any cord-like structures?
So the panel is interrupting you now, and panel says, okay, well, you have examined that patient and you measured the vitals. His blood pressure is fine, temperature is fine, pulse rate is around 90, respiratory rate is fine, BMI is a little high. Then you look for pallor, icterus, lymphadenopathy, that was all negative. Okay, you check his head, neck, and you checked for any focused head and neck and neurological examination you have done. So far, you found that there is no tenderness while palpating head. In the eyes, there is no lacrimation, flushing, or conjunctival injection. pupillary size and light responses are normal, visual acuity, visual field is normal. You checked for eye movement and fundoscopy. There is no papillary edema. Eye movement is no pain. All right. Then what you did is you look for oral hygiene as well. Nothing like that. You examined ear, nose, looking for any signs of ear infection, no signs of sinusitis or any bulging tympanic membrane. Then you checked her head, and his head, and you looked for any temporal artery, looking for any giant cell arteritis, any pain over that area, but that's negative as well. So you look over the face for any sinus tenderness, okay? In the neck, you look for lymphadenopathy, cervical tenderness, stiffness, and you check for carotid buoy, all normal. Complete neurological examination is all normal. Blood sugar level is normal, okay? So what's your differential diagnosis for Jamie?
I see the examination findings are normal, in normal range. My provisional diagnosis for this patient is tension headache. However, in my differential diagnosis, I should like to rule out, first of all, a migraine headache, cluster type headache, temporal arteritis, even though and meningitis and other sinister causes like intracranial mass, intracranial hemorrhage, meningitis, and some other rare causes like trigeminal neuralgia, sinusitis, I think refraction errors, and dental infections, ear infections.
Very good. Okay. Now, what investigations would you do for this patient?
I'll ask red flags particularly, and most concerning headache causes in history to rule out, because to diagnose tension headache, I should rule out all the organic causes first, but and also detailed physical examination. I would like to check full blood count, erythrocyte sedimentation rate, at least to rule out any infectious cause. And
you're talking about ESR, right?
ESR, yeah, erythrocyte sedimentation rate. And for this patient,
I would suggest you say CRP.
Okay? CRP, okay. And in the history, I couldn't mention, but in the history, I would like to emphasize on psychosocial history a lot.
Very good. Very good.
Because I couldn't ask. I should ask more about mood, appetite, sleep, anhedonia, and if the patient is depressed, maybe suicidality and the support. And if the patient is taking alcohol, coffee, caffeine, and smoking, because they are all triggering factors, and also sleep.
Well and what's your management plan for this patient?
First of all, for the management plan, the education is very important.
Very good.
So I will educate the patient about tension headache. Tension headache. What is tension headache? There is no organic cause, but you feel this pain is real. I believe you're having a pain, but this is not because of an organic cause. So I will first of all focus on non-pharmacologic management, reassurance of the patient after telling what is tension headache, what are the causes, and then maybe lifestyle management, like smoking, quitting. I'll check the patient is, I couldn't remember, it's not written here, I think. If the patient is smoking, I will organize another booking. And nutrition is important. I see the body weight is a little bit high, so or maybe I'll refer the patient to dietitian. And alcohol is very important to be consumed in standard, 2 standard drinks, less than 2 standard drinks in a day, less than 10 in a week. And exercise, caffeine intake should be limited. And self-relaxation techniques like yoga, exercise, hobbies, and working. I see that he's very busy. So limiting the working hours is very important here, taking time to relax and to have sleep, and not skipping the meals, because hypoglycemia even can trigger tension headache. And simple analgesia, paracetamol can be given, but the problem here is I didn't emphasize count in the differentials. Medication overuse, headache is another differentials here. So if the patient is taking more than 15 days in a month, then the patient might suffer from.
Time's up.
Okay.
Very good, Dr. Olgan. I'm really happy with the way you proceeded. It's
CBT, another thing is I'll take key 10 and key 10 questionnaire to have a subjective idea.
Yes, you are going to screen for depression. Very good. Okay. So good job. I'm very happy with the way you went with the flow, and you performed really, really well. It's just that I would like to say time management is an issue. So when are you, how are, like history, practice 5 minutes for history so that you have time for next task. Okay. And what are your differential diagnoses for Jamie? So be crisp, like my first or most probable diagnosis is tension headache. Secondly, it could be cluster headache, migraine, could be this, could be giant cell arteritis, could be sinusitis, could be an ear infection, it could be trauma to the head causing subarachnoid hemorrhage, subdural hemorrhage, other than that, epidural hemorrhage. So be specific. Okay, so you don't have time. So like you don't have to explain with differential diagnosis, you just say 4 or 5 things in a blink of 4 or 5 seconds. Okay, so when they say what are the investigations required for this patient, so always stick to the tasks. Okay, they're asking for investigations. Okay, I'm going to consult with my supervisor because I feel like it's a clinical diagnosis. So I feel like the mandatory investigations like CT scan or MRI are not necessary at this stage until or unless patient is under fear that he's having some cancer or anything like that. All right, then I'm going to do basic investigation. If my supervisor agrees to that, like full blood examination, CRP, cholesterol, lipid profile, blah, 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 liver function, kidney function test, urinary, just to make sure everything else is fine. And nothing else is the cause of headache in my patient and no other ailment is going on. Then management plan, talk about the management plan, always talk about health pathway in the management plan and involving your supervisor if he's happy with the management plan I made. Okay, so you did really, really well. And I would say bravo, well done, good job. Okay, so you talked about tension headache. Now let me teach you about cluster headache as well. Okay, everyone happy? Okay. Okay.
All right. Sorry, Dr. Hafsa. I'll just interrupt a little bit. So, Dr. Ulgan, I was also happy with what you have done. Just a few things will be my feedback in here is that the first thing is I found that if your patient is talking, never interrupt in between. The thing is that let the patient tell that what actually they feel. So I know the time is always in our head. I will always encourage patient to talk and talk. And at one point they will stop. And in PESCI, they don't bother too much. So always just like initially, initially when you ask an open-ended question, let them talk. And after that, you start asking questions because they most of the time give you a lot of real good information that you might even miss in this case. So that's also like in the initial part, I feel that that's one thing I would suggest. And other than that, I think do some more role plays with any of the partner if you have. It will also improve the timing. It will also improve the confidence. The main thing is that a lot of doctors are there, have that much knowledge, but still they pass interview. The only reason is that their confidence. If you have confidence in your voice, you can pass any interview, trust me. You just need to be like, you just need to show the face to that panel that yes, I am I am a doctor who can perform. And it doesn't mean that I am overconfident. I know my limitations. I know when to ask for help, but also whatever I am saying, I know what I'm doing. So if you can at least show it to the panel, it's fine. Okay. All right. Thank you, Dr. Ugen, and Dr. Hafsa, you can continue. Sorry for that.
All right. Thank you so much, Dr. Arshan, for contributing. Okay, so now I'm going to talk about cluster headache. All right. So let's see. So first of all, usually the first question is, how are you going to approach this case? So as I told you, one liner for each case. I'm going to the waiting room, invite my patient to the consultation room. Meanwhile, I will make sure to look at patient's general appearance to look for any signs of emergency. I will see if the patient appears to be too distressed, if there is any change in the level of consciousness, patient appears too pale, fly-nosed, or if there is any kind of protective posture. All right. If you just say, I'm going to look for any signs of emergency, it's all right. Okay. In the consultation room, I'm going to try a good rapport with the patient, make a good rapport, make the patient comfortable, be very empathetic, and I'm going to ask open-ended questions and be an active listener, explore my patient's ideas, concerns, and expectations. All right. So you would hardly take 30 seconds to say all that, so in order to save your time. Then I will make sure the patient has a confidentiality statement I have given to the patient. Then I will ask about Socrates, okay? Always ask about site onset character radiation, aggravating relieving factors. That's it. Before that, what are you going to ask? Can you tell me on scale of 1 to 10, how bad is your pain at the moment, with 10 being highest? Okay. Are you allergic to any medication? When was the last time you took your painkiller? That's it. Okay. Then based on his response, I'm going to give the patient appropriate painkiller. All right. Okay. Then, yes, that's what I was talking about. Always ask about site, onset, character, radiation, aggravating, relieving factors. You ask about like this, patient is going to usually tell you all that I have pain over this, I take this. So always, take a pen, paper in your hand and cross whatever the patient has told you already. So you don't ask again and waste your time. Okay. So in IME, you are allowed to have a paper and you can write whatever you want. Okay. So then it's important to ask, is it the first time you're having this headache? Is it getting worse? Then other than that, is it like constant on and off? How frequently it occurs? Is it related to any specific time or any specific situation? Is it like nocturnal in pattern or diurnal in pattern? Is there a specific pattern of the pain or it's just random? Okay. Then if the patient didn't tell you about any aggravating or relieving factors, you can ask about specific factors, such as if there is any, any specific food that caused this headache, any missed meal that caused this headache, if you have any fever, coughing, sneezing, any travel sickness, or if the headache is before menstruation, to look for premenstrual syndrome. All right, any strong odor, noise, bright light, so or any halos in front of your eyes, that's to rule out the migraine. Okay, so talk about these so that the panel knows that you know about the differentials. Okay, so anything helping up with this pain? Have you used any massage? Resting helps or not? Sleeping in a dark room helps or not? Any medication? Okay, have you taken any medication or blah blah blah? Okay, so then you ask about the associated symptoms. Okay, so if this headache, you're seeing any flickering lights, spots, zigzag lines, that's for migraine. Any unusual sensations like pins and needle sensation in the face, arm, or any change in the problem or speech, that's what you're concerned about, a tumor or a bleeding inside the brain. Okay, then you can ask about any nausea, vomiting, phonophobia, any symptoms of cluster headache, such as runny nose, runny eyes, very important, or any facial sweating, any drooped eyelids, swollen eyelids. Okay, so you are talking about glaucomas, cellulitis, everything that could cause headache. Okay, then you are asking about fever, drowsiness, dizziness, eye pain, any discharge from the eyes, ear pain, discharge from ear, cough, chest pain, facial pain. So move from head to toe again. Okay, so that's it. Any pain, stiffness in the neck, any jaw pain, any weakness, unusual sensation in the body, any difficulty in the gait or balance, any fall or near fall. Then you can talk about rash, skin changes on his face and other parts of the body, any visual problems or vision changes that has happened recently after this headache. Okay, all right. Then you have to ask about anything special that may happen before static headaches, like any anxiety, any recent trauma, any recent travel, or any recent infection. Okay. Then, other than that, you can ask about general health questions, any weight loss, any lumps and bumps in the body, any excessive tiredness, excessive thirst, that's for diabetes, any change in weather preferences, that's for thyroid. Okay. All right. Then any past medical, surgical history you should know about, any over-the-counter medication patient is taking. Okay, if they are taking, then you have to take full medication history to rule out medication overuse. Okay, then you have to talk about allergy history, any recent health checks, that's not important. Then you can talk about family history of migraine and cancer is important. Okay, then psychosocial history, very important. Ask about sadhana questions, smoking, alcohol, drugs, medication, and exercise. So that's all that you can ask. Okay, home situation and stressful situation he might be facing at home or work. Okay, so I cleared my AMC clinical recently, and I was in February. So I was doing a case of with a real patient in AMC clinical, and I asked, any stress at home? And he said, no. Then I asked, any stress at work? And he said, yes. I have been so stressed out at work. I have been promoted and blah, 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 blah. So, like now, like it's better to ask a question like, are you stressed about something? That's it, saves your time. If he's stressed about at home, work, or any life situation, he would tell you. So better to rephrase your question like that to save your time. Then, okay, how are you going to examine the patient with a headache? Okay, so again, a one-liner. First of all, what I'm going to do is wash my hands, take permission from the patient, and by telling the patient what I'm going to do and how I'm going to do it. And also, if you're going to do a private area examination, I will offer a chaperone to respect patient's privacy and dignity. First of all, I will note his patient's general appearance. If he is irritable, agitated, he appears stressed, I will notice facial appearance to look for any signs of trauma over the face, any drooping of eyelids, any swelling over the face, especially over eyelids, any sweating, any nose or ear or eye discharge. I will notice if the patient is cachectic or obese, or if there is any slurred speech. Then I'm going to do general examination. I will look for pallor. I will look for icterus. I will look for any sweating, rash, lymphadenopathy, any signs of dehydration. Okay. Then what are you going to do? I'm going to make sure that my blood patient is vitally stable. I will check for blood pressure in both standing and sitting position, looking for postural hypotension. That could be a cause of headache. Then I'm going to look for pulse, respiratory rate, temperature, BMI. Then I'm going to check his hands, look for any nail changes, any tremors. I will check the pulse, capillary refill time. Then I will do focused head and neurological examination. In the head, I'm going to palpate the scalp, look for any pain over the exact area of the headache. I will look for temporal area for any swelling, any redness, any pain, and any hardness, nodularity, any tenderness. Then I will palpate temporal artery as well to detect the pulse. In the eyes, I will look for any lacrimation, any discharge, any flushing, any conjunctival injection. I will see if pupil appears to be of same size, and I will see the pupillary size and light responses as well. Look for visual acuity, visual field, eye movements, fundoscopy. Usually in IME, they do not ask you in detail, how are you going to check visual acuity, visual field, how are you going to check for eye movements. If someone from the panel asks, then you can say that, okay, To check visual acuity, I will ask the patient to sit at a distance of 6 meters, cover their eyes one by one, and read the lowest line in the Snellen's chart. And that's how I'm going to do it. And if they wear lenses or if they wear glasses, I will ask them to wear it while doing that. So you have to, usually in IME, they do not ask these questions, that how are you going to check visual acuity or how are you going to check eye movement. Then I'm going to look at the ear and nose. In the ear, I will look for any signs of ear infection or otitis media, looking for any tympanic membrane bulging or any redness. And nose, I will look for nasal discharge. Then I'm going to face, I will palpate the face and sinuses for sinus tenderness. In the mouth, I will look for oral mouth ulcer, check oral hygiene, any postnasal drip. Then in the neck, I'm going to look for lymphadenopathy, cervical tenderness, stiffness, and checking for carotid bruit. Very important is to look for cervical tenderness and stiffness. If you skip it, they might fail you. So usually they have a key in which there are some points written that if the candidate missed this, he's marked fail. If the candidate, so cervical tenderness and stiffness is important in this case, and checking for carotid bruit is important as well. Okay. Then I will do complete neurological examination to look for any focal neurological deficit. So you can say that I already checked the third, fourth, and sixth cranial nerve by doing eye movements. And I'm going to assess, I'm going to check for cranial nerve. I'm going to do complete upper limb and lower limb neurological examination as well. If you say that, they are not going to ask you anything else usually they do not. Okay. Then I'm also going to check for other cranial nerves. Then you can see that I'm going to assess cerebellum function by coordination test, heel, shin, finger, nose. Usually they are covered with upper and lower neurological examination. Then I'm going to assess cognitive function with mini mental state examination. If in history my patient tells about any problems or changes in memory and concentration, I will do a quick cardiovascular system and abdominal examination looking for any abnormality. Okay. Office test, blood sugar level is important in this one. Okay. All right. So investigation. So yes, I will consult with my supervisor about the necessity of imaging. So just I was like talking about with Dr. Olgan, that if they ask you what investigations are needed for this, so always be specifically answer that question first before saying anything else. Okay, so say I will, because it's a clinical diagnosis usually, so I will consult with my supervisor if there is any necessity of any investigation. Okay, imaging is only necessary if there is any recent head trauma, progressive headache, focal neurological deficits, if there is vomiting, there is personality changes, headaches by exertion, coughing, or sexual activity, recent change in a headache with worsening frequency and severity, or if there is past history of malignancy. Okay, otherwise you do not need to do any imaging like CT scan or MRI or anything. Okay. All right, what is your differential? So first of all, like all the types of headache, you can say that that make at least your four differentials: cluster headache, tension headache, migraine, medication overuse headache. So these are your four differentials just regarding the types of headache. Then serious secondary headaches, trauma, subdural hemorrhage, subarachnoid hemorrhage, then giant cell arteritis, tumor, abscess, stroke, infection in the brain, meningitis, metastatic lesions, encephalitis. So like you can have loads of disease with headache. Okay, so say as many as you can in few seconds or less than 30, less than a minute. Make sure you just take 30 seconds with that. Okay. So it's not necessary to say all the differentials. You can say 4, 5, 6. That's normal. Okay. So depends what was given to you in the role play, or if what was given to you in case discussion. Okay. So with case discussion, you can say loads of differential, because in case discussion, usually they do not give you full history. Okay. Then management. So for management, you can say that, first of all, I'm going to explain to my patient about what cluster headache is. So I will tell that cluster headache, it appears in cyclical patterns, okay, can last from weeks or months, and usually followed by long periods of relief. Okay, so it's severe on one side of the head. For example, some patients have at the back, some patients might have So I might have nasal discharge, red eyes with that. Okay, so I will reassure my patient that it's not serious. Okay, it's not life threatening, and usually the prognosis is good. Okay, so even sometimes you do, when they say, okay, what's the prognosis of, for example, say lymphoma or non-Hodgkin lymphoma, and you do not know. Say, I'm going to check into the health pathway and make sure I'm telling the right thing to my patient. If you say something false, the panel will mark you fail. If you say, I'm going to check into the health pathway, they will not mark you fail. Okay, so then what are you going to do is treatment. You can say that there is no cure for cluster headache. So the goal is to decrease the severity of the pain, shorten the headache period, and prevent the attacks. So I will tell my patient that there is no absolute cure, but it can be managed. So I will advise him on lifestyle management based on SNAP protocol. That is to avoid tobacco, limiting alcohol, daily exercise, have a healthy life. Okay, healthy diet. So alcohol can be a trigger for people with cluster headache. Okay, so it's usually better if you ask them to avoid alcohol. Okay, so non-pharmacological advice is to avoid triggers, especially alcohol. Foods that contain nitrites, such as beets, garlic, meat, other than some strong odors, for example, petroleum that can cause severe cluster headache. Certain medications, such as nitroglycerin. Okay, so then they can ask them to make a diary to record the triggers. Okay, have them a consistent sleep schedule. Okay, that can help with having fewer cluster headaches. Okay, deep breathing exercises help. So oxygen therapy is given to patients who have severe cluster headache. Okay, so deep breathing exercises helps as well. Introduce Health Australia support group to the patient. Arrange a family meeting. If patient has stress, anxiety, I will advise some relaxation techniques like meditation, yoga, breathing, hypnotherapy. Okay, so yes. Okay, then I review my patient 1 week later, or I will check into the health pathway to see the best interval to review my patient. All right, then you can evaluate patient's response to treatment and deciding on tapering the medications. Okay, so I will ask my patient to come back to clinic or emergency department in case they have severe headache, any neurological deficit, any fever, neck stiffness, vomiting, severe confusion, drowsiness. Okay, I will give reading materials to my the patient about cluster headache to my patient as well, and I will consider referring to counselor or psychologist to help patient cope with the patient and the headache attacks. Okay, so if it's unresponsive to medical management, I will refer my patient to neurologist. Okay. So this is just another information about cluster headache. It mostly affects people who are 20 to 40 years of age. It may be missed and as uncommon in general practice, typically in bouts of 6 to 12 weeks, every 1 to 2 years. Okay, so it often occurs at same time of day and year, separated in periods, separated by periods of freedom from headache. So it like waxes and wanes. Okay. So it can be severe, very severe, unilateral, orbital, supraorbital, temporal. So it like the site can vary. All right, can last 15 minutes, 3 hours as well. All right. So sometimes it can be with nasal discharge, sometimes with eye discharge, sometimes with facial sweating, sometimes even with constricted pupil, ptosis, edema. Usually they do not give you these conditions because they know that you can misdiagnose it then with conjunctivitis or anything. Usually they just say headache. In IME, the good thing is the cases are not complicated. So it's crisp single case. If it's migraine, it is going to be migraine. You're not going to confuse it with tension headache or cluster headache. Okay. So what do you give for acute episode? Usually oxygen for 10 to 20 minutes, 100% helps some people. Sumatriptan or intranasal lignocaine on the affected site can provide relief. All right. Usually analgesics like Panadol, Panadine 4 are not effective. So in the case, there is usually a clue that they took Panadol and they took Panadine 4 and nothing helped. All right. So other than that, preventive treatment that can be given. So there is a criteria whom to give preventive treatment. So I will look into the health pathway to see if my patient fulfills the criteria of preventive treatment. Okay, so usually if they have, I'm not sure, I will have to check it in the health pathway, but it's like if they have 3 attacks in a week, then you can start this preventive treatment. Even if you do not know it, they won't consider it as a criteria to fail you. All right. So other than that, what else is, yes. So these are the red flags for which you usually have to refer. Sudden severe thunderclap headache. Okay. Severe headache with signs of systemic illness. First severe headache in a patient who is greater than 50 years of age. Severe headache associated with recent head trauma. Recent onset headache in young female with papilloedema. Persistent focal neurological deficit. Severe headache with an anticoagulant therapy. So these are red flags because you are thinking about now if there is some bleeding going on in the brain, especially any subarachnoid hemorrhage, subdural hemorrhage, or any because the patient if any stroke or any infection going on in the brain. So that's very important to make sure you do not miss any red flag. Okay, usually because you are giving PESCI for GP, the cases usually they give you, they do not have red flags, but sometimes maybe some people may get a case that can have red flag, and then make sure you do not miss it. Okay. All right. So investigation, what would you do? Full blood count, just after consultation with your supervisor, ESR and CRP, especially if patient is 50 years, greater than 50 years. Okay. Then sleep study, if there is morning headache and you're thinking about overnight sleep apnea. Then imaging, CT, MRI, only if there are any red flags or you're thinking about any space occupying lesion or anything like that. Okay. So other than that, that's not important. Okay. Yes. Okay. So there are some worrying features which are recent onset over weeks. Okay. Severe enough to wake patient at the night. Progressive non-episodic headache without remission, vomiting, but no other indication of migraine. Previous malignancy, non-episodic headache with fixed or fixed neurological signs and symptoms, personality or cognitive changes. All right. Okay. All right. Okay. So we have done this case, and so far, everyone happy so far?
All right, Dr. Hafsa, thank you so much. So I think like we will not start the next case today because it's just a trial class. We will see that if we just go through some of the question and answer now in the last few, maybe just half an hour, we will just discuss the general PESCI related queries. And also we might just go through a general discussion about the course. That will be the, yeah. All right. So now, as you guys can understand from Dr. Hafsa's presentation today, that there is a difference between AMC clinical preparation and PESCI preparation. Clinical preparation, if you just need a very small amount of information for a particular case, and just like a very superficial knowledge. But for PESCI, for any specific case, you can see that you need a little bit more information. And the reason that we are discussing it with you, it means that it is actually important. And they can ask anything for a particular topic, anything. So that's why that the cases that's actually important for the exam, we would advise you to go through it in detail, just like how Dr. Hafsa is doing today. It's actually like this, which means that you need to know each and every part of a particular case. For cluster headache, if we say, we need to know what's the main criteria to diagnose it. We need to know that, like, is there any particular investigation that can diagnose this condition? We need to know a little bit more from the health pathways. You can just give it a read and find out what are the emergency criteria, what you should do if a patient comes to you as a cluster headache. Are you going to send the patient to hospital for 100% oxygen, or you are going to just treat the patient in your GP clinic with something else? You also need to understand that when to make the referral to a neurologist. You also need to know that what will be your preventive medication and when are you going to consider it, which means that in PESCI, you are actually a doctor who is managing a patient. It's not about just knowing a particular diagnosis. Like in clinical, it's more important that if you can diagnose that condition, management will be up to the registrar or up to the specialist. But in a GP setting in PESCI, you are the doctor who is actually managing the patient as a whole, right? Obviously with the help of your supervisor, but they actually ask the questions in a way that you are supposed to know about this particular topic, everything about it. So it's a little bit more reading is needed for these cases. Now, you might be thinking that how am I going to finish all of this? Because there are hundreds and hundreds of cases. That's the idea, that we are going to go through the important cases that's mainly appear in the IME or RACGP. And if you can cover or finish those things, most of the time you will be fine. Now, the first one, the latest course that's going to start, that will be mainly focusing on IME, but also if you know these cases, more or less same. RACGP cases are also pretty much same, although there is a little bit difference, but still the idea is same in any kind of PESCI interview. Okay, now before we move on to more discussion about the course, I would just go through a little bit about the PESCI and things. Now, when you start the course with us, the class that I am going to have with you is mainly focusing on discussing about the GP practice, giving you a general idea how this mainly works, and also a general idea about PESCI. Because to start your preparation, you actually need to have a basic idea about it. Otherwise, you will just, if I ask a lot of you, you'll think that what is PESCI? So basically, as Dr. Hafsa said, that PESCI is just an interview, and it's a pre-employment interview. That means you are going to start as a doctor, and it's an interview to start working in a particular practice. So for appearing PESCI, you need a GP offer from a clinic. Once you get the offer, then you can go for the PESCI. PESCI is basically required, like every job offer that you get or every position that you get, a separate PESCI is required for that position. And if you pass PESCI for, let's say you have passed PESCI in a Queensland GP practice, you can't transfer that PESCI result to a practice in NSW. So that's not going to happen. So it's every GP offer that you are getting, a new PESCI, like you have to appear the new PESCI, okay? And all of the PESCI results, even if you pass or fail, it will go to APRA. Now, let's say you have failed the first PESCI. Will it affect your next result? No. It's actually not like that. It's mainly, even if you fail PESCI for the first time, the PESCI panel is going to give you some recommendation that why they have failed you, like what you can do better. So that is what Dr. Hafsa has said initially about the supervision plan. So whenever, even if you pass, there is a plan that what you should do to improve yours. So that's important to get an idea that what actually if you fail in the first PESCI, then in the next PESCI, have you actually improved yourself on that part? So that's also important, that what measure that you have taken to improve yourself in those sectors which your PESCI panel has recommended. Now, we already said that each PESCI will last for 12 months. The very important thing is that you need a supervisor, and the GP clinic that you are getting offered, you need to ensure that that clinic is happy to provide a full-time supervisor for you, right? Like, let's say you have got a GP offer, and then next month you appeared PESCI for this clinic, and somehow that supervisor left the clinic. That means it's actually very shame, and there is no other supervisor in that clinic. So you will be just doing the PESCI for no reason. So it's very important to talk to the practice manager. So practice manager means in a GP clinic, this is a position who actually will first talk to you about recruiting you. So you have to be very clear with them that they are happy to provide a supervisor for you, and they are also happy to provide enough time for you. We always say that go to the practice before you appear the PESCI. Have an idea that where it is, and get a general idea about the practice. How many doctors working there? How many consultation rooms are there? How many treatment room is there? How many receptionists working there? How many nurse or allied health team is working there? So it means that if you actually go to that practice for even a week, if they are happy, and just get a general idea how this practice actually works, that actually gives a huge confidence in your PESCI interview. So go there, say that you want to do an observership for a week, and you just want to be with the supervisor just to understand how this works. If they actually allow you this thing, that means that this is a good practice for you. All the GP practices are private practice. They can, if they don't want you, they can say to you that, well, in the next 1 month time, I would like you to leave this job. They can tell it to you. Okay, so private job is something that you can't actually take a lot of actions against them, unlike the public hospital. So that's why it's important to know that practice so that you can get enough support during your preparation. Okay, like if your supervisor is not good, if you don't like them, if the practice seems a little bit rough, it's not a good idea to start practicing there, because you don't want to have a bad experience for the first time that you are working in Australia. That impacts a lot in what you are going to be in the next 5 years. Okay, so that's one thing. Now in PESCI, the evaluation that usually the panel does is mainly about your communication skills. Like are you actually able to take a proper history? Are you able to do a proper examination? Do you know your limitations? How is your judgment about a particular case? Are you a professional doctor? Okay. And do you understand that a patient can be Aboriginal and Torres Strait Islander? I always say that initially when you introduce yourself with the patient, just ask this question that, are you Aboriginal or Torres Strait Islander? Or the better question is, do you identify yourself as an Aboriginal or Torres Strait Islander? It's very important to get a cultural idea that what actually they prefer. So, because culturally, a lot of things will be different. Case by case, you need to, even if it's a case of Aboriginal having any mental health issues, you will always say that you would like to involve a Aboriginal healthcare worker. Okay, so that's important to know that if that particular person having are they actually identify themselves as Aboriginal or Torres Strait Islander? So those are important things. Like this tiny little bit things actually helps a lot in your exam. And if you don't know it, then it actually interfere with your exam result also. So we will go through some general interview questions that initially you will face with the PESCI panel. I will actually do that with the course. So when I will take the classes, then I will just initially go through some of the common general interview questions, like tell me about yourself, and like how long you worked in your country, and tell me about your country GP practice. So a lot of questions they can ask you initially, which you actually should have a proper answer in your head. And always make sure that everything that you say to the PESCI panel should be according to your CV. If your CV and your conversation doesn't match, that's really not a good idea. So go through your CV, whatever you have written, make sure that that also matches with your conversation. Okay, so that's actually most of the thing I wanted to discuss before we go to the course discussion. But there are a few topics that I would actually like to go through with you during the course so that you understand the initial aspect of PESCI panel. And then obviously these cases, the mentors that we have chosen, Dr. Hafsa has passed clinical exam, and she also passed PESCI. Dr. Yasmin will be also one of your other mentors. She has also passed clinical and PESCI. Then I will take few classes, and maybe someone who also passed clinical and PESCI, they might just add few classes. But Dr. Yasmin and Dr. Hafsa will be your main mentor for this course. Okay, so both of them are very, very good, because without being good, they can't pass both clinical and PESCI. So give them some time, because they also are like doing these teaching sessions for the first time. So I'm sure that things will become more and more better once they start the course. And obviously you will learn a lot. At least the main idea is that you passed PESCI in your first attempt and you start working as a GP in Australia. That's the most important part. Now, I would encourage anyone to ask any questions that you would like, and Dr. Hafsa or me will be able to answer your questions.
Thank you, Dr. Arjun, for your input. Some people have written questions in the chat. I can see that. Dr. Mubin Akhtar requested to start class in time. So thank you, Dr. Mubin. We did start in time. I think it was at 8:05, but we will make sure to start in time. And please, everyone, note that overtime is according to Sydney. If you are in different state, that the time can change, okay? So yeah.
Yeah, and the classes will be between 7 to 9. So, and usually for this course, the schedules are strictly maintained, because this is just a very short course, like 6 weeks course, and the schedules will be strictly maintained throughout it so that you can finish it in time. There is no problem with that.
Okay, so Dr. Sandhu sent me a private message that is RACGP conducting PESCI interview in Victoria because they have a job offer from GP practice in Victoria. As far as I know, yes, RACGP is conducting PESCI interview in Victoria. All right. So then Dr. Samreen Hassan asked that if recency is needed to get an offer from the GP clinic. So recency is usually not needed to get an offer. It improves your chances of getting an offer. Like it improves your chances of getting a job if you have recency. All right, because for applying for PESCI, for clearing PESCI, recency is not required, but when you apply for registration, EHPRA asks for recency until or unless your hospital or clinic gives you a re-entry to practice plan. And usually clinics do not give it, or hospitals are very reluctant to give it. I don't know why. All right. So Dr. Asma asked that if someone can clear PESCI after part 1, then is there any time period for clearing part 2? If then, how much is the time period? Okay. So Dr. Asma, what happens is that after clearing PESCI in part one, so usually you get registration for 1 year, then you have to renew your limited registration. So you get limited registration under supervision after clearing the PESCI in part 1. And English test as well. So you have to renew it every year. then I think there is you can renew limited registration 3 times, and overall I think after that you are asked to clear part 2. If you cannot clear it, then you can apply, you have to write to HPRA that you are doing some courses, because there was one doctor studying with me. He was working as a GP under limited registration and was trying to clear part 2, and he has been applying for renewal of his registration by telling that he has been taking HEAL courses, and he has been trying so hard to clear AMC part 2. So if you show, it's just that you have to keep showing AHPRA that you are trying your best to clear part 2, and it's up to them that they renew your registration or not. So for 3 times you are allowed to renew your registration. That's what I know. After that, you have to give AHPRA or like a reason that why you are trying and
Yeah.
you couldn't clear it. Okay. So
That's right,
thank
Dr.
you.
Hafsa. It's actually 3 years for a limited registration. And after 3 years, APRA will be on your back for a good amount of time. So you have to show a very good reason that why you are still not passing. You have to show that you actually appeared exam, even like you have tried few times, you didn't make it, or at least something you have done, you have to show. So, and also they might ask for a supervisor assessment from you, that what you are doing, if you're doing it right. So all of this will work, that if they are going to give you an extension.
Yes,
and unfortunately, if you can't give that, then that registration will be over and you have to start from the first, which means reappearing the PESCI, getting everything again from the start. So that's usually the main issue.
Okay, thank you so much, Dr. Harshan. So thank you, Babi Tilotoma, Dr. Baby, for your nice words. Dr. Harshani, yes, you need, Dr. Harshani asked, do we need to do the GP assessment after clearing PESCI and AMC clinical? Yes, Dr. Harshani, we do need GP assessment. So when you get a job, after every 3 to 6 months, there is a assessment form that is filled by your supervisor, and AHPRA requires it to see if you are working genuinely and how good are you working. And based on that form, your level of supervision gets decided that whether you will be given level 2 after level 1 or not. Okay. So what about Dr. There is someone logged in as iPad and they asked, what about the second supervisor? So usually there are 2 supervisors. One is principal and one is co-supervisor. So if you are working as level 1, one of them need to be present with you at the clinic every time you are seeing a patient. Okay. So Dr. Mehdi Masood asked, 1 week observership is okay. So it's up to you if you want to do observership, and it's totally your choice. Some people apply and they are far away, like they're in other states, and they cannot do observership. So it's up to you if you want to do it. Many people pass even without observership, but yes, observership do gives you an edge, and it gives you it makes like you to know the clinic, where the things are, and how the work is done in the clinic. So it's a good idea to observe, do the observership. Okay. So Dr. Tina asked, if I have a gap in my practice, will it affect my PESCI results? And how can I minimize this gap before the interview? So usually IME, the good thing with IME is they do not ask about a gap. And because I don't know anyone if they asked about them that why do you have this much gap and or not. So one of my friend, she gave PESCI through ACRRM, and the first thing they were very much concerned about, even before giving her any case, was that, oh, you have so much gap. How are you going to see the patients? And she said that even before starting her interview, the panel was very biased and they were like willing to fail her. She said that she made mistakes as well, but still she felt that because of the gap, it did affected her. So what you can do to minimize is go back to the home country. That's the best thing that we can do, is go back to home country and do at least 1 month recency. If you cannot do that, do CPD courses, CPD points that can help. Otherwise, if the panel asks you, how are you going to do how are you going to cover your gap? You can say, yes, panel, I'm aware that I have this gap in practice. After clearing my PESCI, I'm going to go back to my home country and do my recency of practice to cover this gap in practice, so that the panel has an idea that, okay, this doctor is willing to work on her gap as well. Okay. Dr. iPad, okay, I'm going to call you Dr. iPad. Are these doctors already practicing in Australia? So this is personal information I don't want to tell you right now, but yes, I am. Okay, so Alice's son, and she asked, how long should we prepare for PESCI? It's up to you, Dr. Alice. So, Dr. Alice, it's like you have to, it's up to you how much time you can give to your study. And usually 3 to 4 months is okay. If you have prepared for clinical, 3 months is good for you. Okay. So Aisha asked that when is Dr. Yasmin will be taking class? Why, Aisha, you don't like me? Just kidding.
It's fine.
So Dr.
Okay, no worries. So,
you can answer.
I will answer that question. So Dr. Yasmin and Dr. Hafsa is actually, we are actually making the schedule in a way that both of them take classes in every week. So it will be in that way. So today we have started with Dr. Hafsa, and then Dr. Yasmin will start in the first or second week of your class. Okay.
Okay, thank you.
And one other question, Dr. Hafsa, for you, that I have a job offer from Victoria. Is RACGP conducting a ski interview in Victoria?
Yes, doctor, I already told that doctor that yes, RACGP is conducting interviews in Victoria. As far as I know, they are.
Thank you.
Yes. Okay, so Dr. Mubin Akhtar asked that if the panel is ruling out few things by saying that the findings are negative, do we still have to include that conditions and differentials? So what I did, Dr. Mubin, that I said that it could be it could be, for example, in the headache case, I said, yes, most likely it could be tension headache as my patient was really stressed about their job, but it could be migraine, but still least likely as the patient didn't have any history of halos or any flashing lights or any zigzags or any kind of typical history of migraine. It could not be subdural hemorrhage because the patient didn't give any particular history or signs and symptoms of that. So just like this, I kept on going. So it doesn't matter if you include that in differentials. So as long as you say that's least likely, so it's okay. Then Dr. iPad, okay, you said re-entering plan is hard to write, but there are some organizations which can do it, but you need to pay. I heard 4 years. Okay, so it's up to the clinic or hospital. So like they allow you the re-entry plan. Okay, so it's up to them if they want it. It's not like just writing it. It's like if the hospital or clinic agrees to it. Okay, so because if they are like they are accepting a doctor with gap, if they want them to have a re-entry plan or not. Okay, so that's up to clinic or hospital. Then Dr. Asma asked, if we couldn't clear part 2, then we need to appear PESCI again. No, you do not. You do not until or unless you're going to change the practice you're working. Okay. Are there detailed notes of cases that will be available? Yes, there will be. Dr. Olgan said, can we obtain general registration in a year who are already on provisional registration? As far as I know, Dr. Olgan, yes, you can. Because you, if you are provisionally, you have cleared AMC2, you work in a GP clinic, yes, you can get a provisional general registration. But make sure, guys, those who are permanent resident, they cannot work in MM1 area. They have to work in MM2 above location, MM2 or MM2 above location. Those who are temporary residents, they can work in MM1 location as well. And for permanent residents, to get general registration, there is some monetarium that they have to work in remote areas or MM2 above areas for for like these 10 years, or it depends upon the area. The remote the area is, the less time you have to spend over there to get general registration. But if you are temporary resident,
so
then you can
I'll just give some ideas on that part. Is that like what happens is any permanent resident doctor will need to have two kind of restrictions. One restriction is that they will need to be in a 3GA program, and also during the 3GA program, they can only apply in MM227 and also a DPA area, which is district priority area or distribution priority area. So these two you will need to always find out from the health workforce locator. So if you search it in the Google health workforce locator, you will be able to find out which areas are actually fulfilling that criteria, which means you will need to see that this is the clinic I am applying for. And that's the issue, that many clinic, they will offer you a GP offer, but they don't know this staff, because a lot of doctors are working in Australia who doesn't need this. So they will just give this offer to you because they need doctors, and they don't even bother about this criteria. So you are supposed to actually know all of this, that, well, if this practice actually fulfill my criteria. Because at the end, when you actually go for Medicare provider number to start working in here, or you go for any registration, that clinic will be rejected anyway if you don't fulfill the criteria. So I will always say that if you actually get an offer, or even if you are trying to get an offer, first find out if that clinic fulfills these two criteria. If you are a temporary resident, then it doesn't matter, you can work.
Okay, Dr. Archan, I'm sorry, I have to go. Please take it from here because I have to attend to my daughter now. I'm really sorry.
Okay, that's fine. All right, thank you, Dr. Hafsa, for this. So we'll just go with the other questions.
Okay, thank you so much, everyone. Bye.
Can anyone directly sit into RSEGP fellowship exam without passing MC clinical after 3 years of practice? Yes, they can. So you can get into a limited registration, but in that case, you will need to have that 3 years equivalent experience in GP in your country. And if you have that, then yes, you can have a limited registration, and then you can go into a 3GA program like PEP, which is now called Fellowship Support Program, FSP, or any of the other ones like MD-RAP or anything like that. And if you are in that program, then after finishing that program, you can appear the RSEGP fellowship. And if you get the fellowship, you get general registration anyway. So that's one other thing can be done. That's right, Dr. Javed. So if IMG joins a fellowship program and complete it, no need for AMC clinical. We always say that, Dr. Afsha, so it's very important. If you're actually having a work gap, make sure you do some CPDs. And you'll be a RSCGP member or ACRAM member. So which member you are doesn't matter. Just make sure you have some CPD done. It's a really a good answer when the panel asks you that, well, you have a very, like, you have a 10 years gap. What have you done? So you can say that, well, this is the reason why I could not do work, but throughout this time I have tried to improve my skills. So I have done this course, and my last recent course was this, and also I'm planning to go to my country to get my recency. So all of these things you can actually say to them, and in that way, where they're actually trying to fail you, they will be impressed. Know that this doctor had some trouble. Now he or she wants to come back to this. And she actually was not just sitting around. She did lots of courses. She tried to improve herself. So doing some CPD, if you are a RSCGP member, is always good. And RSCGP member, they get a lot of free webinars, podcasts, a lot of other things. So do that and add it to your CPD portal. Yes, Dr. Asma, you should go for a RSEGP assessment before starting. And yes, regarding the course, if you are unable to attend any session due to work, you will be getting all the notes and recording access. Yeah, so you have a proper schedule for not everyday cases. We can't write everyday case that we are going to discuss, but obviously we'll try to make sure that you get a proper schedule. And even if it helps to know the cases that we are going to discuss so that you can prepare, that can be arranged as well. And for anyone, fellowship program, any IMJs who are permanent resident, they cannot work in MM1. You can only work in MM1 if you are not a permanent resident. No, this one, Dr. Benish, it will be a full schedule because it's a 6 weeks. We'll have full schedules initially. There is nothing you need to do to become an RSCGP member. You just need to make some payment. So go to the RSCGP website and find out the membership option and just go through like what options actually is good for you. Most of the time it's the IMG associate. So that's what you can go for. Yes, the idea is that if you don't have 3-year full-time experience as a GP in your country, then actually getting directly into the GP settings is very hard. So if you have 5 or 6 years of experience as a GP in your country, or if you can show it with proper documents, then yes, then do the assessment because assessment will be important part of your registration. And yes, PR can work in MM2 plus and DPA area. That's right, Dr. Benish. All right, guys. So I think like that's it for tonight. The course is going to start from 29th of May. And my plan is not to start on 29th of May. We'll start on 1st of June. So we'll give you some time to do the process of admission because just within 2 days, you might not be able to do all of this. So the plan would be to start the classes from 1st of June and we finish on 12th of July. That will give you the 6 weeks of course. Okay, so the classes for those of you who are already admitted, please note that we just started this course. The notes and recordings will be added after the classes so that you can go through it. And also just make sure that the classes are not going to start from 29th, rather it will start from 1st of June, that is Thursday. And the classes are mainly Monday to Thursday, 7 to 9 p.m. Okay, and we are going to do more cases every time that we do this class. It's not just like today because today is just the initial part of it, but the idea is to do a lot of role plays and case discussion so that you get some idea about it. As you can understand, it's more about getting to know about these things. It is also important to get an idea how PESCI works and what the panel actually wants from you. So if you can do that, then most likely it should be fine. So I will not do too much sessions. That's the honest thing. I will do few sessions, maybe 3 to 4 sessions with you guys. And because Dr. Hafsa and Dr. Yasmin, they are pro in this, and they will be mainly doing the sessions. And you will actually get more help from them rather than me. Or from me, you should get the idea how actually GP settings works, how actually PESCI panel actually ask questions to you and what they want from you. So that will be more important from me that you get. And the cases actually will be a much better idea that you go through with those two doctors. Okay, so we'll see how it goes. And obviously, your feedback is the most important part that we always work through. If you don't like something, if you think that this can be added or can be modified, or if you think that particular mentor needs to do something for more improvement, we're always happy to do that. So this is all about improving and making sure that you are satisfied, just like you are with our AMC clinical course and the MCQ course. Okay. All right. So thank you, everyone. Have a good night. We will look forward to start this course with you and see where we go. And there is always a start of something nice and good. And there was a time 5 or 7 years ago, I think, when we started our AMC course, there was like, I think I remember only 30 students maybe joined the class. And now we have like thousands of doctors who are preparing with us, thousands of doctors who have already started working in Australia. So there is always a start, and in that way, we gradually improve ourselves and making sure that you also thrive with us. Okay. Thank you. Take care. Have a good night.